This recording will go over Chapter 27, Nutritional Therapy and Assisted Feeding, in the Fundamentals textbook. The goals of nutritional therapy are to treat and manage disease, prevent complications, and restore and maintain health through an appropriate diet. A therapeutic diet for each patient is prescribed on the primary care provider's order. You can assist your patients in meeting their nutritional goals by completing thorough nutritional data collection. Monitor the patient's food and fluid intake and document their response to therapy. Patients who may need assistance with food and fluid intake include those who have paralysis of the arms, visual impairment, intravenous lines or other devices in their hand or arm, problems breathing or swallowing, known as dysphagia, or severe impairments or weakness. Patients scheduled for surgical or invasive procedures may have special nutritional needs. Ideally, this patient should be well nourished preoperatively. Preoperative patients are usually placed on an NPO status for up to 12 hours before the procedure. This means no food or fluids by mouth. Always check with the surgeon for exceptions to this practice. These exceptions may include diabetic, cardiac, or any other medications that can be taken with a sip of water that will ensure patient stability during surgery. Postoperative patients progress from a clear liquid diet to a full liquid diet. Clear liquids are started when the patient has return of bowel sounds detected by auscultation. Foods that are clear fluids at room temperature include foods that are clear fluids at room temperature, and liquids that are clear are included on the clear liquid diet. This includes gelatin and popsicles. A full liquid diet can be used as a step between clear liquid and mechanical soft or regular diet. Full liquid diets include all fluids, custards, ice cream, sherbet, puddings, and cooked refined cereals. Patients recovering from surgical procedures that involved manipulation or of surgical incision in the stomach or bowel may progress to a soft diet before attempting a regular diet. As the patient's condition progresses, the diet is advanced to regular. Anorexia nervosa is a psychological condition characterized by the restriction of caloric intake, a very low body weight for the developmental stage, and a pathological fear of becoming fat, as well as a severe disturbance in body image. This is prevalent among adolescent and young women. However, adolescent and young men can also be affected. If not corrected, anorexia nervosa can be fatal. Treatment is a combination of nutritional intervention, behavioral modification, and psychological counseling. The patient needs to be willing to remain in psychological therapy and follow nutritional recommendations to achieve treatment success. Bulimia nervosa is an eating disorder characterized by episodic binge eating, followed by behaviors designed to prevent weight gain, including purging, fasting, using laxatives, and exercising excessively. Psychological and nutritional counseling is necessary. The treatment plan can include nutritional supplements and monitoring of patients after eating to ensure that the purging does not occur. This condition needs to be treated with behavioral modification in order to stop these practices. Binge eating is defined as recurrent episodes of consuming significantly more food in a defined period of time than most people would eat under similar circumstances. Binge eating disorder is one of the most common eating disorders. However, it often goes undiagnosed. Women are most affected by this disorder. Nursing interventions for patients with feeding and eating disorders include nutritional management, behavioral modification, patient education, and monitoring progress. Obesity rates continue to rise, and obesity has become a national health threat. The CDC estimates that 39.8% or 93.3 million adult Americans are obese. Obesity is the second leading cause of preventable death in the United States. Many factors contribute to obesity, including genetics, environment, poor eating habits, lack of knowledge about good nutrition, medications, body physiology, age, and gender. Nutritional modifications and physical activity to manage obesity must be individualized and incorporate all factors relevant to that patient. Hypertension, gallbladder disease, joint disease, and some forms of cancer are more common with patients in obesity. Long-term success of weight management programs are low. Approximately 5% of obese people who reach their desired weight management goal can maintain their weight status over a 2 to 5 year period. A lifestyle change is key. Physical activity designed to match the patient's ability is usually a component of the weight management programs. Nutritional therapy will depend on the patient's degree of obesity. Obesity is characterized as mild to extreme, and it is determined using the body mass index chart. Effective nursing activities for weight reduction assistance include encouragement of low-calorie diets, plant-based or vegetarian diets, appropriate portion size, activity recommendations, and behavior modification. Bariatric surgery, which reduces stomach size and/or reduces calorie and nutrient absorption, has been touted as the most effective treatment excuse me, the most effective treatment to provide long-lasting weight loss for people with extreme obesity. However, quality weight management programs are also effective. Nutritional data and collection and counseling are important through pregnancy to reduce any risk of complications such as low birth weight infants, gestational diabetes, and pregnancy-induced hypertension. Counseling should emphasize management of maternal weight gain and the taking of prenatal supplements as prescribed. Individuals who use alcohol, smoking, and other substances will often present with nutritional deficits when entering healthcare facilities. Substance use interferes with food intake by decreasing the appetite, decreasing financial resources for food, and substituting calories in alcohol for calories in food. Thiamine deficiency is often present with alcohol use. Liver damage is common in patients with substance use because of the increased stress of metabolizing excessive alcohol and other substances. Cardiovascular disease includes diseases of blood vessels, hypertension, myocardial infarction, and heart failure. Nutritional therapy is focused on reduction of saturated and trans fat, cholesterol, sodium intake, and red meats. Excessive saturated fat and trans fat will lead to a development of atherosclerosis, the accumulation of fatty deposits on the walls of blood vessels. Narrow blood vessels will increase the workload of the heart, resulting in hypertension as the heart attempts to circulate the blood. Dietary management will include reduced intake of saturated fats, trans fats, and cholesterol. The blood contains 3 types of cholesterol. High-density lipoprotein, or HDL. This is known as your good cholesterol, and it tends to cleanse the vessels of the fatty deposits. Low-density lipoprotein, or LDL cholesterol, will increase these fatty deposits on the vessel walls. Very low-density lipoprotein, or VLDL, will serve as a carrier for triglycerides in the blood. This is a type of fat linked to atherosclerosis and coronary disease, and we should keep these levels low. Recent research is suggesting that concentrated sugars can play a greater role in the development of heart disease than the consumption of saturated fats. Vitamin D can prevent cardiovascular disease by decreasing inflammation. Vitamin D can be manufactured by the skin in response to sunlight exposure or consumed in the diet. Large amounts of sodium can cause fluid retention. Increased fluid volume and edema can also lead to hypertension. Dietary approaches to stop hypertension, or a DASH diet, is low in sodium and high in fruits, vegetables, nuts, seeds, legumes, and low-fat dairy products. This can lower blood pressure even in healthy people. Salt substitutes and no-salt seasonings can also be used in cooking. Diabetes mellitus is a disturbance in the metabolism of carbohydrates and other nutrients and the use of glucose by the body. There are 2 main types of diabetes. Type 1 diabetes will occur when the beta cells of the pancreas stop secreting insulin. Insulin is then needed to transport glucose across the cellular wall. and this type of diabetes typically develops at an early age. Type 2 diabetes accounts for 90 to 95% of all cases of diabetes. This occurs when glucose receptors on the cell membrane lose their sensitivity to insulin. Insulin is normally secreted in normal or excessive amounts, but the receptor sites are not allowing the glucose to enter the cell. This type of diabetes is primarily common after age 40, but it's now even appearing in children and younger people. The incidence of diabetes is increasing at an alarming rate in the United States. Of particular concern is the prevalence of type 2 diabetes among children, adolescents, and young adults. The goal of nutritional therapy for patients with diabetes is control the amount of carbohydrates in the diet to maintain the blood glucose level at 70 to 120 milligrams per deciliter. The ADA recommends a diet of moderate complex carbohydrates, including pasta, beans, whole grains, rice, and fruit. Patients with diabetes are at higher risk for cardiovascular disease, hypertension, kidney disease, blindness, and stroke. Develop a plan taking into consideration the type of diabetes, the patient's activity level, and whether that patient is overweight. A blood glucose level of 180 milligrams per deciliter or below will indicate an acceptable post-meal level. Thanks to antiretroviral therapy, severe malnutrition associated with human immunodeficiency virus, or HIV, and acquired immunodeficiency syndrome, or AIDS, is far less common today than it was a few decades ago. Still, someone is said to have HIV wasting syndrome when they have lost 10% of their body weight, and this is typically associated with severe diarrhea and fever. Nutritional therapy is directed towards replacing fluids and electrolytes, fostering weight gain, replacing muscle mass through protein intake, and maintaining the strength of the immune system. Calorie intake should be increased for patients with HIV and AIDS, with an emphasis on protein intake. Dietary considerations will include maintaining a high calorie intake, increasing their protein intake to maintain or increase their muscle mass. Offer bland, soft, or pureed foods when the mouth is painful. Add thickening agents to liquids if indicated by the swallowing evaluation. Add seasonings to help food taste more appealing. Encourage small, frequent meals. Complete the assessment of health and nutritional status. This is important for any patient diagnosed with HIV and AIDS. Patients who have high care needs, malnutrition, cardiovascular or nervous system disorders, or dementia may be unable to tolerate oral fluid and food intake. Some patients may show common signs of swallowing problems, such as coughing when drinking, drooling, or having food remaining in the mouth. A speech-language pathologist can conduct a formal swallowing evaluation and recommend a management plan. Many patients who aspirate will show no obvious signs or symptoms like coughing. Liquids can be thickened to help prevent aspiration. Solids can be ordered at 4 different texture levels. Level 1 is pureed, pudding texture. Level 2 is mechanically altered. This is moist and minced to a 1/4 inch maximum. Level 3 is advanced. This is moist and bite-sized, and no hard or crunchy foods. And level 4 is regular, all foods. There are several types of enteral tubes. Tubes can be placed through the nose into the stomach, known as nasogastric tubes. Placed directly into the stomach, known as gastrostomy or percutaneous endoscopic gastrostomy tubes, or placed into the intestine, known as jejunostomy or duodenal tubes. Nasogastric tube placement is usually a temporary measure to provide nutritional support. The NG tube may be used for other purposes, such as stomach decompression, removing the stomach contents before or after surgery, obtaining laboratory specimens, gastric lavage for patients with gastrointestinal bleeding or for removal of ingested toxins, and for medication administration. When enteral or intestinally absorbed nutrition is needed over an extended period of time, a small bore feeding tube, about 8 to 10 French, can be inserted. Small bore tubes are soft, flexible tubes that need to be inserted by a skilled person using a guide wire or stylet. This would be something known as a Dobhoff tube. Active patients can find the tube restrictive and inconvenient. Nursing care of patients with NG tubes involves insertion, irrigation, administration of tube feeding, checks for placement, checks for residual volume, and removal of the tube. Explain the procedure and its benefit to the patient before beginning insertion. Proper placement of a small bore tube needs to be verified by an X-ray examination. A tube that is not correctly positioned or poor body positioning can cause aspiration. Elevate the head of the bed for 30 to 60 minutes after a feeding to ensure that residual volume is not aspirated. These pictures can be seen on page 503, showing where the different tubes would enter in the gastrointestinal system. Monitor NG tubes frequently. Irrigate the NG tube with 30 to 60 mL of sterile water solution to ensure that it is patent. Monitor for complications such as constipation, nausea, diarrhea, hyperglycemia, and electrolyte imbalances. A PEG or percutaneous endoscopic tracheostomy tube is used when a patient requires a long-term nutritional support and cannot take oral nutrition. The tube is placed via endoscopy. A PEG or PEG tube can be removed easily when there is no longer any indication for it. Care of the PEG or PEG tube is similar to that of the NG tube. Check the tube placement at least every shift and before feeding or administering any medication. If the tube becomes dislodged, notify the charge nurse and primary care provider immediately. Follow the facility policy and licensure regulations regarding reinsertion of the tube. Daily care of the tube involves washing the tube insertion site with soap and water. Observe your patient for any abdominal distension or aspiration. Abdominal pain, vomiting, or respiratory distress can be a sign of a complication. Before feeding or administering any medications, measure the amount of residual fluid in the stomach. If a continuous feeding is in progress, you should stop the infusion before checking for any residual volume. Use an irrigation syringe to withdraw the stomach contents. If the residual volume is greater than 500 ml or per your agency policy, replace your withdrawn fluids and document the residual. Then notify the RN or primary care provider and delay any further feeding for a specific period of time if your facility policy states to do so. Keep the patient's bed elevated at least 30 degrees at all times if the patient is on a continuous feeding. This is to facilitate the stomach emptying and prevent any aspiration. Tube feedings can be continuous or intermittent. The type and amount of the tube feedings are prescribed by the primary care provider and usually range from 240 ml to 360 ml per feeding. A daily amount of 2,000 ml is generally sufficient to meet the patient's nutritional requirements. If a syringe is used, it should be a 30 ml or larger, and the formula should flow in by gravity. It should not be pushed in as a bolus or in large amounts. Allow about 10 minutes for an intermittent feeding to flow into the tube. Flush the tube with 30 ml of water after each feeding to prevent any clogging. A feeding pump can be used. Set the rate on the pump or regulate the drops through the drip chamber to control the amount given. This device can be used with NG tubes, PEG tubes, or jejunostomy tubes. Tube feedings can contain a high level of glucose to provide the necessary calories. They should be given slowly to prevent any diarrhea and glycosuria, which is glucose in the urine. The preferred method is to give the feeding slowly over a 24-hour period. Total parenteral nutrition is a method of delivering complete nutrition through a catheter placed in a large central vein. A large central vein with high blood flow is needed to dilute this solution rapidly. This can be done through a peripherally inserted central catheter, or PICC. These options are used for patients receiving long-term therapy, such as those with massive burns, intestinal obstruction, inflammatory bowel disease, AIDS, and cancer. It is called peripheral parenteral nutrition, or PPN. Parenteral nutrition does not involve the digestive system, and it absorbs the nutrients directly through the bloodstream. It's important to maintain aseptic technique when performing TPN administration to reduce any risk of catheter-related infection. Monitoring of PPN and TPN should be ongoing. Carefully begin the infusion rate and monitor it throughout your shift. If the rate is lower or higher than the prescribed rate, adjust it to the correct flow rate. Never attempt to catch up if the rate has slowed. The rapid infusion of glucose can be harmful to a patient. Always document the discrepancy and then report it to the charge RN and the doctor. Be sure to look at some principles of tube feeding on box 27.3 on page 512, as well as in table 27.4 on page 512, monitoring peripheral parenteral nutrition and total parenteral nutrition. It'd be important to pay attention to the flow rate in that box. When assessing our patients, the first step in assessment is to determine the reason for the tube. Once the tube is in place, assess the function of that tube at least every 4 hours for the first 48 hours of feeding, followed by about every 6 to 8 hours thereafter in any non-critical patients. Always monitor for signs of complications such as nausea, vomiting, abdominal distension, abdominal pain, and respiratory distress. Nursing measures will include frequent mouth care using a toothbrush to prevent drying and cracking of the mucous membranes. Swab the oral cavity with a gauze pad, cotton swab, or oral sponge that has been moistened by normal saline or water. Other nursing actions will include securing the tube to the patient's clothing to permit maximum activity without pulling on the nares, preventing kinking of the tubing, and keeping the environment clean, quiet, and well ventilated. When documenting, be sure to document the following: the size of the tube inserted and how the patient tolerated the procedure, the amount of formula and fluids given, and the result of the tube feeding or medication administration, the measurement of the tube, how placement of the tube was checked, usually 2 methods are recommended, as well as the amount of and character of any gastric residual at each feeding, presence or absence of bowel sounds each shift, how the patient tolerated the procedure, including any problems with nausea, constipation, or diarrhea, and the date and time of any tube removal.